If you have IBS-D, you know the drill. You ate something normal, something you've eaten 100 times, and 3 hours later you're mapping the day by bathrooms. Every meeting, every drive, every coffee. That's not a flare. That's daily life with IBS-D. And it doesn't have to be permanent. At the end of this episode, I will share a cause that is behind up to 30% of IBS-D diagnoses. Most doctors won't test for it unless you ask. If treatment hasn't worked for you, it might be because you don't actually have IBS. Stay for that. If you're in a flare right now, episode 3 first. Come back when it passes. This episode is for the pattern, not the panic. 90% of my bad years with IBS were diarrhea, urgency, bathroom mapping, declined invitations, the slow narrowing of life to the safe meals and the safe rooms. If that's where you are, I've been there. And the part nobody tells you is, most of it is fixable. Not in 3 hours, but in 3 to 8 weeks. This is the IBS-D stabilization protocol. Everything here is a 4 to 8 week trial, not a same-day fix. If you expect results in 3 days, you'll stop something that was about to work. The biggest mistake in stabilization is moving too fast. Quick safety check. If you have rectal bleeding, unexplained weight loss, persistent vomiting, fever, symptoms that wake you from sleep, see a doctor before anything else. IBS doesn't cause those. They need investigating first. I use a 3-star evidence system throughout this channel. 3 stars means meta-analysis backed and guidelines supported. 2 stars means solid mechanism, lighter clinical data. 1 star means the evidence is early. Same system as episode 3. 6 tools. Here's the protocol. Tool number 1, soluble fiber. 3 stars, 1 to 3 weeks. You read that right. Fiber for diarrhea. The kind matters more than the dose. There are 2 types. Insoluble fiber, wheat bran, raw vegetables, adds bulk, and can make IBS-D worse. If high-fiber food has ever sent you running, that's probably why. Psyllium husk is different. It's soluble fiber. It absorbs water and forms a gel in the gut. That gel slows transit, firms up loose stool, and here's the part that surprises people. It works in both directions. One of very few tools that helps IBS-D and ibs-c with the same mechanism. Start with 1 teaspoon per day in a full glass of water. Increase every 3 to 5 days. Target 1 to 2 tablespoons daily. If you go too fast, you'll get gas and bloating, and you'll quit. Slow build wins. These are standard adult doses. If you are on other medications, pregnant, or with kidney or liver conditions, check with a pharmacist first. That conversation's free. Take it. This is the foundation. Start it from week 1. Tool number 2, peppermint oil, daily, not just rescue. 3 stars, days to weeks. We covered peppermint oil in episode 3 as a flare tool. It also works as a daily stabilizer. Multiple randomized trials. First line in several major clinical guidelines for IBS pain. It relaxes the smooth muscle in the gut wall. Same mechanism as prescription antispasmodics without a prescription. The cramping that hits at the same time every day. The pain after meals. The bracing you do without realizing. 180 to 225 milligrams, enteric coated 2 to 3 times daily before meals. The enteric coating isn't optional. Without it, the oil releases in the stomach and you get heartburn instead of relief. Stack this with the fiber from week 1. Don't wait for the foundation to fail before adding the next layer. And one more thing before we continue. Most people who try the low FODMAP diet make a specific mistake that keeps them unnecessarily restricted for years. It's not about which foods you cut, it's about what you never add back. I'll come back to that at the end. Tool number 3, probiotics, 2 to 3 stars depending on strain, 4 to 8 weeks per trial. Honest Framing, a generic probiotic from the supplement aisle, picked because the label says Gut health, that one's unlikely to do much. The research is strain-specific. Different strains do different jobs. The wrong one is the same as taking nothing. The trial rules matter more than the brand. One strain, one product, 4 to 8 weeks. Track your symptoms. 30% or more improvement. Keep going. Less, stop and try a different strain. Don't stack two at once. You'll never know which one is doing the work, which strain, for which subtype, and why. That's episode 11. Tool number 4, prescription escalation. 3 stars, days to weeks. This is the prescriber step, not over the counter. If fiber and peppermint oil haven't been enough after 2 to 3 months, there's a prescription medication approved specifically for IBS-D. Elaxadilin is the most common name. It slows transit, reduces pain, and addresses urgency directly, not a first stop. A conversation with your gastroenterologist when the over-the-counter foundation hasn't been enough. It's not for everyone. Off the table for people without a gallbladder and for heavy drinkers. Your doctor will walk you through whether it fits your specific situation. Tool number 5, low-dose neuromodulators for IBS-D with pain. 3 stars, 4 to 6 weeks. Another prescriber conversation, the one most IBS-D patients are never offered. If pain is your dominant symptom, not the diarrhea, the pain, and the foundation tools aren't touching it, there's a class of medication most people dismiss the second they hear the name. At the doses used in IBS, this class isn't being prescribed for depression. It works directly on the gut's own nervous system to reduce pain signals and slows transit, which helps IBS-D specifically. The effect is in the gut, not the brain. The dosing, the evidence, and how to have the conversation with your doctor. That's episode 15. Most people who needed it were never told it existed. That's why I'm flagging it now. Tool number 6, melatonin, 2 stars, adjunct, 4 to 6 weeks. This one surprises people. Melatonin is produced in larger quantities in the gut than in the brain, where it regulates motility and pain signaling. Small, randomized trials show 1 to 3 milligrams. At bedtime, reduces abdominal pain in IBS, regardless of whether sleep is a problem. Pain and sleep feed each other. Poor sleep raises gut sensitivity. Pain disrupts sleep. If that loop is running for you, melatonin is a low-risk trial worth running. If this is useful, subscribe. The investigation continues across this series, and I don't want you to miss the case files. So, here's the sequence. Psyllium and peppermint oil from week 1. That's the foundation. Run 1 probiotic trial in parallel. 1 strain, 4 to 8 weeks. If the basics aren't enough by month 3, talk to your gastroenterologist about prescription escalation. Episode 15, if pain dominates. Add melatonin if pain and sleep are tangled. Track everything. A simple 0 to 10 score for pain, urgency, and bile frequency daily. That diary is what tells you what's working and what isn't. Without it, you're guessing. Now, the investigation layer. Stabilization manages symptoms. It doesn't remove the cause. If you want to stop needing these tools, that's the investigation. The most impactful dietary change for IBS-D is the low FODMAP approach. About 70% of IBS sufferers respond. And the mistake I mentioned earlier, it's in the reintroduction phase. Almost nobody does it. Without it, you stay restricted for years longer than you need to be. Episode 7 walks the full method and the mistake. If your gut clearly tracks your stress, worse during pressure weeks, calmer on holidays, episodes 8 and 9 cover the 2 gut-brain interventions with the strongest evidence. Both have improvement rates around 70 to 80%. Neither is it's in your head. If bloating and diarrhea hit together, especially after meals, there's a specific bacterial overgrowth that mimics IBS-D and responds to a targeted antibiotic course. Episode 13. And now, the thing I mentioned at the start. If you've done everything on this list and the diarrhea is still running, your life, consider something most IBS-D patients are never told. You may not have IBS, There's a condition where the body either makes too much bile or fails to reabsorb it properly. The unabsorbed bile reaches the colon, irritates it, and triggers urgent, watery diarrhea, often within minutes of eating. It looks identical to IBS-D, but it's treatable, specifically, and the treatment doesn't work on regular IBS-D. Up to 30% of people diagnosed with IBS-D may actually have this. Most doctors won't test for it unless you ask by name. Episode 12 covers it in full: the test to ask for, the treatment, and how to know if you should suspect it. If you still need these tools every week after 8 weeks and nothing has shifted, that's not a stabilization problem. That's a pattern, and patterns have causes. The stabilization work is done. Episode 7 is where the investigation starts. Don't give up. Keep investigating.